All right, I think we will start. Just share the screen. All right. So yesterday we did up till the clinical manifestations of malaria. I'll just quickly go through the falciparum manifestations and then we'll continue with the complications. Am I audible? I think you can chat and let me know if I'm audible. Or should I be louder? Anyways, so the clinical features, malaria first starts with non-specific symptoms like headache, fatigue, abdominal discomfort, etc. After that, you have fever. Now, typical attack of fever has three stages: a cold stage, hot stage, and a sweating stage, right? So, in the cold stage, there is severe headache, vomiting, with skin being cold initially and then hot. In the hot stage, obviously, the skin will be hot and dry with intense headache. The nausea is lesser, but you have a increased respiratory rate. And in the sweating stage, the body is trying to cool down itself. So you have cool and moist skin and a slow pulse. Now, these attacks or the paroxysmal fever or outbursts, they occur with intermittent periodicity, that is of about 48 hours in Plasmodium vivax and ovale, and hence they're called tertian malaria, or 72 hours in Plasmodium malariae, which is why it's called a quartan malaria. Now, the fever due to falciparum may never really be regular because you have all the stages of the parasite in blood at the same time. The other physical findings in uncomplicated cases may be anemia, splenomegaly, hepatomegaly with mild jaundice. Now, from this, we take advantage of this and may use it as a malariometric index, that is to measure the prevalence of malaria in any area. We use what is known as a spleen rate, which is the percentage of children between the ages of 2 to 9 years who have an enlarged spleen. And if you actually measure the average spleen enlargement, then it's called the average enlarged spleen, which is nothing but a more refined measure of malaria. In severe falciparum, you have cerebral malaria, which may manifest as a coma with diffuse symmetrical encephalopathy. On routine fundoscopy, you see four important findings: retinal hemorrhages, discrete spots of retinal opacification, papilledema, cotton wool spots, which are fluffy white spots, along with diffuse whitening of the retina. Convulsions may be seen, and neurologic sequelae, if present, are usually resolvable within 6 months. However, obviously, children with cerebral malaria in their childhood will have a persistent language deficit and a decreased overall lifetime expectancy. This was a diagram we had seen of the fundoscopy of the retina with hemorrhages and white spots, fluffy spots. We also saw that there is hypoglycemia because there is liver failure, so there's failure of gluconeogenesis and increased glucose consumption overall. Apart from that, there may be a an acidosis, which is because of anaerobic glycolysis in the tissues along with renal impairment. Hematologic abnormalities like anemia and mild thrombocytopenia, which leads to slight coagulation disorders. And we saw that transfusion malaria is also an important mode of transfer of malaria. Pernicious anemia and black water fever were nothing but just different names of a complicated malaria. We saw the basic difference between a relapse and recrudescence. Relapse is what is seen in Plasmodium vivax and ovale because of the dormant forms of the parasites called hypnozoites present in the liver, and this may occur in 2 to 3 years. Whereas recrudescence is because of the drugs, because of the parasites which are resistant to the drugs that we had already administered. So there was a previous infection and the parasite was resistant to the drug, so they have remained, and hence a recrudescence occurs. Today we're going to start with what is known as the chronic complications of malaria. Any chronic or recurrent malarial infection may lead to hypergammaglobulinemia, which is increase in the antibodies. It can lead to normochromic normocytic anemia, and we have already seen the reason because the RBCs lose their deformability. Their walls become rigid and more antigenic. And it may also cause splenomegaly. So apart from splenomegaly, what it causes is hepatomegaly, increased IgM, and increased ratio of CD4 positive and CD8 positive T cells. Now all of this leads to increased B cell production, which leads to the formation of cryoglobulins. So cryoglobulins are nothing but masses of IgM. Their accumulation of IgM products, and this leads to increased reticuloendothelial hyperplasia, which obviously spleen is a reticuloendothelial organ, so it ultimately leads again to more and more splenomegaly. So how it may present in the OPD or in any case is there is an abdominal mass with a dragging sensation, and if there is a sharp abdominal pain associated, then it is suggestive of perisplenitis. Now, if there is now because of splenomegaly, although the spleen is enlarged in size, it is not able to carry on with its regular functions. And so what happens is you are more prone to infections. It may also lead to septicemia and death. So if there is an evidence of splenomegaly in endemic areas, then chemoprophylaxis is recommended. And in non-endemic areas, you straight away start with anti-malarial therapy. The next is quartan malarial nephropathy. If you want to break down the words, quartan, if you remember, was the malaria caused by Plasmodium malaria, because the fever spikes occur in every 72 hours, because that is the length or the duration of erythrocytic schizogonia. So quartan malarial nephropathy is different from the renal impairment we had seen as the complication of malaria. Here what happens is because of chronic or recurrent Plasmodium malaria infection, there is a soluble immune complex injury or basically deposition to the renal glomeruli, and this leads to the nephrotic syndrome. Now, if you all remember, in pathology we had done nephrotic syndrome is nothing but characterized by heavy proteinuria leading to hypoalbuminemia, and that leads to in turn edema and hyperlipidemia and hypercholesterolemia. So these were the four most important: massive proteinuria, which is more than 3.5 grams per day, which leads to hypoalbuminemia, leading to edema and hyperlipidemia. This was nephrotic syndrome. On histopathological examination, we see focal segmental glomerulonephritis. If you remember, focal was when it's basically we had two times, focal versus diffuse. So glomerulonephritis, when less than 50% of the glomeruli of the kidney are affected, you call it focal. And when less than 50% of each glomerulus is affected, we call it segmental. So focal segmental glomerulonephritis is less than 50% of the glomeruli of the kidney are affected, and within each glomerulus, less than 50% of its structure is affected, and hence segmental and not global. Now, on electron microscopy, what we see is the splitting of the capillary basement membrane along with subendothelial dense deposits. So that was your focal segmental glomerulonephritis because of Plasmodium malaria infection or quartan malaria. It is also said that Burkitt's lymphoma and Epstein, see these two we know are associated, Epstein-Barr virus infection and Burkitt's lymphoma. But the prevalence of these is seen high in the malarious regions of Africa, and hence it is suggested that they may be correlated as well. But it's not completely definitely proven. Next, we come to the most important part, which is the laboratory diagnosis of malaria. And the gold standard here is the demonstration of parasites in the blood by microscopic examination of the peripheral blood smell. So after a few hours of the febrile paroxysm that we just saw, after a few hours of that, blood is collected by a finger prick. So we are collecting capillary blood and not venous blood. And this is obviously collected before starting anti-malarial therapy because we want to observe all the stages of the parasites. And we make two smears out of it. We make a thick smear and a thin smear. In each, what is important to note is, and because this is not stressed enough, I believe, that we need to count the gametocytes separately. So the number of gametocytes, male and female, are counted separately. Now, in a thick smear, how you prepare it is you take a drop of blood on a slide, you spread it unevenly on a 1 centimeter square area such that it allows printed letters to be read through, or you can read the hands of your watch through it. So it should be that thick, unevenly thick. And then you keep it in distilled water for dehemoglobinization. So you remove the hemoglobin from the thick smear. In thin smear, you may put a drop of blood and you may spread it with another slide like we do for any other peripheral blood smear until there is a tail formation. Now the thin smear has a prognostic value and we are not dehemoglobinizing the thin smear. That is important. At this stage, you stain both of them, the thick and the thin smear, with GMSA or a Leishman stain or any other Romanowski stain. We had learned a list of those for pathology, EMAT. After staining it, the thick smear is usually used to detect the parasites and thin smear is used for identification. And because the thick smear has 20 to 30 layers of cells packed in a small area, it is more sensitive and you are more likely to detect parasites. However, it will not allow you to identify parasites easily, and for that you use your thin smear where the parasites are concentrated along the upper and the lower margins of the teeth. If you remember our discussion from yesterday, we had read that Plasmodium vivax causes the RBCs to get enlarged, and hence all the RBCs get concentrated near the leading edge when you are making or preparing the thin smear. Now, you observe about 100 to 200 fields of thick smear under oil emulsion rings, which is ultimately it comes out over 1000 magnification. If you don't see any parasites after 100 to 200 fields, you put it as a negative for malaria. If you do see parasites, you count parasites along with the WBCs. The reason you're counting WBCs is because you you count WBCs on your peripheral blood smear. You take a TLC count from pathology, and then you count the number of parasites per microliters of blood using the total leukocyte count. So if suppose you see 100 parasites here and 200 WBCs, then and suppose the count for WBCs is say it is 1000. That means it's 500 times. So the parasite will be 500 times per microliter of blood. So number of parasites per unit volume was calculated, and you also obviously identify the parasite on the thin smear because that will help you prognostically as well as therapeutically. Now, based on what we discussed so far, we use other malaria-metric measures. So parasite rate is basically the percentage of children between 2 to 10 years who show parasites in the blood. Again, why we are using only children is because in endemic areas or in areas with stable transmission of malaria, adults would have gained immunity from malaria because of repeated infections, and hence it is not of epidemiological importance. Parasite density rate is the degree of parasitemia. So this is way different here. Firstly, you are counting all adults as well as children. Secondly, on your denominator, you are comparing it with all the positive slides. So suppose I see 10 slides, out of which 5 are positive for malaria. And in those 5, I count a total of 5,000 parasites. Then my parasite density rate will be 5,000 parasites seen in all positive slides, that is upon 5. So that will be 1,000. So parasite density rate is basically the number of parasites seen totally in all positive slides checked, not all slides checked. The infant parasite rate, this is interesting because it's the percentage of infants showing malaria parasites, and this is supposed to be a best indicator for the recent transmission of malaria, because the infant, because it won't be exposed for such a long period as to become immune or to not show even in stable transmission areas, and that's why it shows recent transmission the best. These, along with the spleen rates that we discussed, are more popular in the pre-eradication area where your density of is high and density is high. In the eradication areas, including India, we use the ones I've written on the right hand side. So the first one is annual parasite incidence, which is the confirmed cases during 1 year upon the population under surveillance. They were into 1,000. The annual blood examination rate is the number of blood slides examined. Next is the annual falciparum incidence, which is the number of slides positive for falciparum upon the number of people surveyed. Similarly, we have slide positivity rate and slide falciparum rate. So slide positivity rate is obviously the number of slides positive upon the number of slides examined, and slide falciparum rate is the number of falciparum, number of slides positive for falciparum specifically. I think I made a mistake with annual falciparum incidence. It's the number of people in which falciparum is found positive upon the total number of people surveyed into 1,000. So that was about the microscopy, routine microscopy. Next, we have something which is known as the fluorescent microscopy, where we use staining, which is what is known as the Kawamoto technique with acrid in orange. And parasite nuclear acids, they take up the fluorescent stains. You have to observe this under the fluorescent microscope. So a big disadvantage of this is that a fluorescent microscope may not be available everywhere. Nuclear DNA within the parasite stains green and cytoplasmic DNA, RNA stains red. That is all I think what we need to know. The next is a QBC test, where blood is collected in a QBC or a quantitative Buffy coat tube, and it's centrifuged so that the different layers of blood that we've studied even in the ESR, PCB in physiology, that is done, and the Buffy coat layer is examined because basically the parasites get accumulated there. Because you stain them with a fluorescent dye and you observe it under a fluorescent microscope again, what you see is a brilliant green color in the parasites, and that's how you identify it. So it's definitely more sensitive and more useful in mass diagnosis. However, it's again, you need a fluorescent microscope for this, so it's not very peaceful. This next one is more important because this is what we are practically using right now, rapid diagnostic kits. We have two types. For the first time, detects the Plasmodium falciparum specific histidine-rich protein. It's an antigen, PFHRP2, which is commercially available as the Parasite F test. And the second one detects the LDH antigens, Plasmodium specific lactate dehydrogenase antigens, using immunochromatographic methods, obviously. So this is like a kind of a pregnancy test, but instead of urine, here you're using a blood prick, blood sample. If it shows a line, a band, colored band, it is positive for malaria. Now the first one, that is the PFHRP2 test, it does not differentiate between falciparum and other diseases, but the LDH antigen is specific, so it will show you one line if there is malaria, and it will show you two lines if there is malaria due to falciparum. So the rapid diagnostic test that uses lactate dehydrogenase antigens will differentiate between falciparum and non-falciparum malaria. Now, the gold standard for the diagnosis of malaria will always remain microscopy. However, what is more practically and popularly used are these rapid diagnostic kits. So that were the most important parts of the diagnosis. The next is, obviously, we have other tests like serological tests using indirect immunofluorescence or indirect hemagglutination or ELISA. We can use DNA probes as well as PCR. So this was about specifically the parasite. However, in the medicine ward or the OPD, we also do some other regular blood tests and the other laboratory findings what we find. Firstly, we'll find normocytic normochromic anemia. We've already seen the reason why. Total leukocyte count may be normal. ESR is increased and C-reactive protein are increased because they are acute phase reacting proteins, obviously, and there is a lot of inflammation and metabolic disorder taking place. The platelet count reduces to approximately 1000 per microliters. Like we've seen, there is mild thrombocytopenia with bleeding disorders. In uncomplicated cases, usually the electrolytes and the blood urea, nitrogen, and creatinine are normal. But in severe infections, like we saw, there is increased lactate because there's lactic acidosis. Then you saw renal impairment, so there and liver impairment. So there will the blood urea, nitrogen, creatinine, urate will all increase. There may also be seen hypergammaglobulinemia in the immune and semi-immune individual. So that was about the diagnosis. Now coming to treatment, I didn't really find a lot of time to write this in extremely detail, but giving you a very brief idea about the treatment. Case management, there are three very basic simple rules. Ovine and malaria are not very commonly seen in India. What we usually typically see are Vivax, falciparum, or mixed infections. So for Vivax infections, we use a chloroquine regimen. For falciparum, we use a chloroquine. If it's resistant to chloroquine, we use an ACT regimen. And if it's a mixed infection, that is, it may be a Vivax plus falciparum, then it is the same as falciparum, but you give primaquine for 14 days. So what is the chloroquine regimen? Is that you give chloroquine for the dose is 10 milligrams per kilogram body weight on the first 2 days, followed by 5 milligram per kilogram body weight on the third day. So the total dose is 25 milligrams per kilogram body weight over 3 days, divided in obviously 3 doses. Along with that, you give primaquine 0.25 milligram per kilogram body weight on day 3. Chloroquine regimen, which was given for treatment of Plasmodium vivax. Now, the important points that you consider while giving primaquine is that it is contraindicated mainly during pregnancy, in infants, and in patients who are deficient in G6PD, because it causes hemolysis in G6PD deficient individuals. Now, a little bit about chloroquine before we move ahead, because it is a very important drug. What is the basic mechanism of chloroquine is that it's a rapidly acting erythrocytic schizontocide. So if you remember, we have seen the diagram of the life cycle of the Plasmodium. Here. And the blood schizontocides that we see here. Chloroquine is an example of the blood schizontocide. So it acts on the erythrocytic cycle of the Plasmodium. It gets concentrated in the Plasmodium food vacuoles. And where we saw basically that heme was converted into hemozoin, because heme is toxic to humans, but heme is also toxic to the parasite. So what it does is it causes the accumulation of heme within the parasite, killing the parasite. It gets accumulated in the parasitic food vacuole and inhibits the formation of hemozoin from heme, causing the accumulation of heme, which is toxic to the parasite, hence killing the parasite. This is the mechanism of action of chloroquine. Now, apart from its use for the treatment of Plasmodium vivax or falciparum, it is also used in its chemoprophylaxis. Along with that, it is also used in the treatment of amoebic liver abscess because it reaches high concentrations in the liver. If metronidazole is not able to treat amoebic liver abscess, you use chloroquine. And it is also used as a DMARD, which is disease-modifying anti-rheumatic drug for the treatment of rheumatic arthritis or SLE or Sjogren's syndrome. Now, the adverse effects are pruritus, nausea, vomiting, etc. May cause hemolysis in G6PD deficient individuals, and a long-term administration, especially for rheumatic diseases like we discussed, it may lead to irreversible ototoxicity, retinopathy, myopathy, and peripheral neuropathy. So this was the important things about chloroquine. The important contraindications, as I said, are G6PD deficiency, along with psoriasis, porphyria, because it's ultimately metabolized in the liver, and if there are retinal or visual field impairment. So you need to rule out all of this. The next drug that we are going to see is the artesunate combination therapy. So before we actually go on to the regimen, let us discuss, because I have the diagram here. Artemisinin derivatives, are very rapidly acting blood schizonticides. So the same mechanism of action uh, as chloroquine. I'm sorry, I don't have the notes for. I I don't have it scanned, so I may share it later on. So they act against all human malarial parasites, but they have no effect on the hepatic stages. They are also active against the young gametocytes. So, but not the older one. So it's a partial gametocide and partial blood schizontocide, artemisinin derivatives. Basically, their mechanism of action is that they lead to the accumulation of free radical within the parasites, leading to their death. So they are used obviously when there is a chloroquine resistance. The reason why we combine artemisinin based, why we have a combination therapy, the first is obviously to improve the efficacy. Secondly, the short acting drugs will lead to high recrudescence rates, and hence you combine them with a long acting drug. So by the time the action of the short acting drug is over, you have a longer acting drug. Already the plasma levels of the longer acting drug increasing. And the next is to prevent the selection of artemisinin resistant parasites. So what is the selection of resistant parasites is, suppose I'm giving any drug, not only artemisinin, but even chloroquine. If you give the drug in lower quantities, then the ones that are more susceptible, the parasites that are more susceptible to the drug, they will all die. But there are some parasites that are more stubborn. They need higher doses of the drug, and hence they will live on. Now, when a mosquito bites this human being, what will happen is only the resistant parasites will remain in the person, and they will get transmitted. So the new infection acquired by, say, me, then that new infection will be totally resistant to the drug, because this parasite has been selected. It's a biological and evolutionary selection of the parasite that is resistant to the drug. And hence, one of the most important reasons that leads to the resistance in uh, anti-malarials or any drug for that matter is incomplete or inappropriate dosage or incomplete therapy. So to prevent this, what we do in artemisinin based therapy is we combine. So the various combinations that we use, just one second. So the most important combination that we use here are artemisinin, and sulfadoxine and pyrimethamine. So there are 5 important ones that are recommended by the WHO. But in India, what we use are 2. We use artemisinin, sulfadoxine, pyrimethamine. But in the northeast, there is a increasing resistance seen to sulfadoxine and pyrimethamine. So what is recommended is artemether and lumefantrine. So for the rest of the country, we are using artesunate 4 milligrams per kilogram body weight for 3 days, along with sulfadoxine 25 milligram per kilogram body weight, and pyrimethamine 1.25 milligrams per kilogram body weight on day 1. So sulfadoxine, pyrimethamine on day 1, and primaquine 0.75 milligrams per kilogram body weight on day 2. However, in the northeast, there is resistance to sulfadoxine, pyrimethamine. So what we are using is artemether and lumefantrine. Artemether 20 milligrams per kilogram body weight, and lumefantrine is 120 milligrams. In pregnancy, what we use is quinine in the first trimester. That is the drug of choice. Now, overall, we have these charts given in part. This is nothing but the diagnostic and treatment regimen guidelines. So in areas where your microscopic result is available within 24 hours and there is a suspected malaria case, you take the slide, you send it for microscopic examination. If it comes positive for Vivax, then you treat with primaquine, chloroquine, primaquine for 3 days, chloroquine for 3 days, primaquine for 14 days. Primaquine is what leads to, we have discussed this already earlier, it leads to a radical treatment because it will also kill the hypnosomes. So primaquine has 3 important functions. It is a tissue schizontocide. Tissue schizontocide means that what we had seen in the life cycle here, it will act here. It's a tissue schizoidocyte. It will act on the pre-erythrocytic cycle in the liver. Apart from that, it is also a gametocyte. It will kill the gametes, and it is a blood schizoidocyte. It's not the only thing it's not acting is on the attachment, so it's not a positive profile. Anyway, now so that was for vivax. For falciparum, it's usually falciparum is chloroquine resistant, so we use ACT. In northeastern states, you use ACT-AL and artemether and lumefantrine for 3 days with primaquine single dose. In all other states, you are using artesunate, sulfadoxine pyrimethamine for 3 days, primaquine on second day. Similarly, for mixed infection, you're using the same treatment, and if it's negative, then obviously if there is no malaria, so you don't treat. Now, in areas where microscopy is not available within 24 hours and you are using a monovalent rapid diagnostic test, then if the total falciparum rate is greater than 1% and plasmodium falciparum is greater than 30% in that area of the last 3 years, then you do rapid diagnostic and you prepare the slide if malaria is detected. So if it's positive for falciparum, you treat accordingly. If RDT is negative, then you wait for the slide. So you are confirming with slide. If the area is not very high risk for falciparum, then you wait for the slide result. You give chloroquine only if you are suspecting malaria high clinically, or because the area is endemic malaria. And areas where obviously microscopy is not available and bivalent RDT is used, then you do a blood test with the rapid diagnostic test, and if it's positive for falciparum, mixed or bivax, you treat accordingly. If it's negative, you don't give any antimalarial treatment. Now the next part is the National Vector-Borne Disease Control Program, which I don't think is very interesting to be discussed actually like this, but I'll just skim through it. So basically, in 1953, we launched a national malaria control program. All right, and in 1958, basically because of the high success, what happened is we changed the name to National Malaria Eradication Program because we thought that we were going to eradicate malaria completely. But obviously that didn't happen. And by 1977, we had a modified plan of action. With 2002, what we did is we made the National Vector-Borne Disease Control Program, NVBDCP. And in 2005, it became an integral part of the National Rural Health Mission, with active case detection done by the multipurpose workers and the ANMs. So they visit every household fortnightly and they collect blood smears in endemic areas. That is what is known as active case detection. Passive case detection is done in every fever case that comes to the hospital or to the ashas. If anyone goes with fever and if the area is high for malaria, it has a high endemicity for malaria, the passive case detection is done. So it's mainly done by the health volunteers and ashas. So what they did, basically the goal of right now is to eliminate malaria by 2022. That is 2 years from now, in category 1 and 2 districts. So now they have categorized the districts based on the annual parasite incidence. I repeat what annual parasite incidence was. It was the percentage of it's the number of confirmed cases in 1 year upon the population under surveillance multiplied by 1000, because it's an incidence. So based on the API, if it's less than 1 per 1000, you call it a category 1 district. If it's greater than equal to 1 but less than 2, then you call it a category 2 district, which is in its pre-elimination phase. Category 1 was in its elimination phase. And if API is greater than equal to 2 per 1000 population, then you call it a category 3 district, with where it's in the intensive control phase, intensively trying to control malaria. So your basic strategies for the control are diagnosis and case management as per the guidelines that we just discussed. The second one was integrated vector control measures. which we discussed. I'll just share the screen. We discussed the integrated control measures along with the life cycle of the vector malaria here. There are three important measures. The first measure of integrated vector control are the anti-larval measures, which can be environmental, chemical, or biological. The second was the anti-adult measures, where you take indoor residual spraying, etc. And obviously, you have the personal protective measures like uh, uh, long-lasting insecticide nets and insecticide-treated bed nets. The third one is about surveillance and epidemic response. So what you do is you survey the control program and you see how the epidemic is responding to it. So the way the survey is conducted is you identify what is known as active foci. Active foci are nothing but they are circumscribed areas or localities situated in formerly malaria endemic areas with either continuous or intermittent epidemiological factors that are necessary for the transmission of malaria. So you identify those foci and you classify them into either active foci, residual foci, or cleared foci. And you survey them, you identify the foci, classify them into active, residual, or cleared foci, and accordingly you plan your action next. And the cross-cutting and supportive interventions include your behavior change communication. You are convincing people to use more and more bed nets, etc. So that was it. It was quite a short discussion on malaria. We finished the second half. I hope you have understood. Thank you for joining in.